Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a case of PC rent with lens matter and IOL drop into the vitreous cavity. The patient was operated elsewhere. I have taken up this case. I am placing a tracker about 3.5 millimeter away from the limbus in the inferotemporal quadrant. This is the left eye of the patient. The patient has come on his own. The patient has not been referred by the operating surgeon. I have placed a tracker, 23 gauge tracker, and this is the irrigating line. And now I am making two sclerotomies. This is a sclerotomy at around 2 o'clock with a embier knife, and this is another sclerotomy at around 10 o'clock or 11 o'clock. This sclerotomy is because I didn't have a 23 gauge cutter in my stock, so to use this 20 gauge cutter I have made this sclerotomy. And here is the epinucleus, vitreous, everything mixed up. This is the IOL, and this is a chunk of epinucleus, and it is coming by the cutter easily. It is good that the operating surgeon removed the nucleus. And now I'm doing vitrectomy as far as possible. I'm using an irrigating contact lens to view the retina. To see the periphery, we have to ask my assistant to depress the sclera by a cotton taped Johnson bud. Nice vitrectomy can be done with this irrigating contact lens. So those who cannot afford biome can do basic vitrectomy with this instrument. Now I have injected triamcinolone acetate to see the rest of the vitreous strands, to identify the rest of the vitreous strands. Assistant places the irrigating contact lens, and now I can see a lot of vitreous strands are there all around the lens. As I cut and remove those vitreous strands, the IOL becomes free. And now my plan is to put some iris hooks, because the people didn't dilate the iris, and capsule has the synechia in some places between the iris and the capsule of the lens. So people dilated only this much. Now to clean the cortical matter and to see the possibility of implanting a sensor multipiece intraocular lens in the sulcus, I'm going to place these iris hooks. These are from Madhu Industries, Delhi, India, and this is the second iris hook, and now I can see the capsule and the cortical matter, and here I see some blood clot at 2 o'clock. So I go again with the cutter and remove this blood clot. In this case, I thought I will have to place an iris claw lens or sensor multipiece intraocular lens as glued IOL, but I am looking into the possibility of placing the sensor multipiece lens in the sulcus. Let us see what happens. Yes, I am able to clean the cortex very nicely because there is no vitreous strands around. This cortical matter is coming out very nicely. I am taking care not to cause any damage to corneal endothelium. Now I am going to place some more iris hooks superiorly to view the lens matter and capsule in the superior aspect. This is the 5th stab incision, and here is the hook. And now to clean this cortical matter, I made an entry through 6 o'clock, and now I am able to clean this cortical matter very nicely. I never thought that it will be possible to clean the cortical matter so nicely, but because of the iris hooks, this is becoming possible. Yes, now it looks great, and I am hopeful that I will be able to place an intraocular lens, the sensor multipiece intraocular lens, in the sulcus. But there is a extension of the rhexis towards 3 o'clock, so I cannot place the haptics there. I have to place the haptics at 6 o'clock and 12 o'clock. Now I open the SICS wound to remove the intraocular lens from vitreous cavity and place the sensor multipiece lens in the sulcus. Now, after opening the SICS wound, I go again with the light pipe and a forceps, and I ask my assistant to come to place the irrigating contact lens over the cornea. Now as she comes, I can see the intraocular lens sitting over the macula, but I cannot touch the portion which is sitting over the macula. I must be beyond the arcades, superior vascular arcade or inferior vascular arcade, and try to hold it. I tried to hold it in superiorly, but I could not. So I go there and hold the lens, the haptics. There's a gap in the haptics. using that gap I could hold and I bring it out. Now this lens, when I remove this, it should not damage the cornea. So what I'm going to do is I'm going to use viscoat, not viscoat, orocoat, combination of chondroitin sulfate and sodium hyaluronate. At this time I ask my assistant to stop the irrigation, and now I inject this viscoat. I keep injecting and remove the lens. Thus I could protect the corneal endothelium. Now this is viscoat again, because I want to place the lens in the sulcus. The leading haptic goes into the sulcus. I can very well see that, but how to put the trailing haptic into the sulcus? For that I place the iris hook again, and now I will be sure that it is being placed over the sulcus. Now I dial the lens. The leading haptic comes superiorly and the trailing haptic goes to 6 o'clock, and the lens is very nicely stable in the sulcus. And now I just have to remove the iris hooks. Remember, the iris hooks is very easy. There's a silicone guard. Just retract the silicone guard, unhook the pupillary margin and remove the iris hooks. This is very easy. Just turn it in such a way that it comes out easily, doesn't cause any scratch on the cornea. Now I go again into the vitreous cavity, because there is a lot of viscoelastic substance that has dropped into the vitreous cavity. I should not leave it like that. So I go again and do a very nice removal of this viscoelastic substance. This is HPMC plus chondroitin sulfate plus sodium hyaluronate, all mixed up. And the sodium hyaluronate is looking like LPFC, liquid perfluorocarbon, and it is coming gradually. I can see that the macula is very healthy, and there's a little bit of hemorrhage, but it is not at the fovea, it is on the temporal side of the fovea. I can see that the optic nerve is very healthy, so I am hopeful that this patient will get very good recovery. And I am very happy that I have been able to place the lens in the sulcus. This has saved a lot of time. If I have to use the same lens as glued IOL, then the surgery time increases by about 20 to 30 minutes. And after removing the viscoelastic substance, I could find some more vitreous strands all around and removed that very nicely. I am using Faros from Oatly. Cut rate is 5000, flow rate is 200, flow rate is 30, and vacuum is 200. So this is a very satisfactory job. I had only 1 year's training in vitreoretinal surgery. I cannot do complicated vitreoretinal surgeries, but this basic level knowledge that I have is helping me to manage this case. And these patients cannot afford to go to big places, and we do this kind of surgery with very minimal charges. Because the patients cannot afford. Now I closed the sclerotomy at 2 o'clock. Now I am closing the SICS wound by 3 interrupted sutures. Yes, in this case I opted for interrupted sutures. And now the knot is buried in the tissue. Now the sclerotomy at 10:30 o'clock is closed by suture. This is 10O nylon. Almost suture I use is 7O vicryl, but this 10O nylon is good. It gives less irritation to the tissue. So this is nicely closed. The conjunctiva was opposed by 2 releasable sutures. Now I am going to remove this irrigating trocar. I am ready with this chopper, blunt chopper, to press the wound, to massage the wound, and the wound closes. This is not leaking and it doesn't require any suture. How to say that it is not leaking? If it leaks, the conjunctiva will swell up. And now I am removing the visco from the anterior chamber. At this time I am very careful not to come near the corneal endothelium. I am over the lens and I am not moving here and there. I am just removing, being at on place. Now I am going to check if the wound is side port wound is self-sealing or not. Yes, I find that it is self-sealing, so the side port doesn't require any suture. Now this is moxifloxacin. I am using moxifloxacin to hydrate the side port. And now I have to form the antechamber. The eyeball has become soft, so again I use BSAs to form the anterior chamber. Yes, it is done. Now I check the pressure, it is okay. And now I check the integrity of the wounds by cotton tipped Johnson bars. Feel the pressure. Put some moxifloxacin over the ocular surface and conclude the case. These are some post-op pictures. Next day, 15 hours after surgery, cornea is clear, anterior is quiet, intraocular pressure is normal, vision is 6/18. These are the 90D pictures. Optic nerve head is normal, macula is healthy. The patient is very happy. Thank you very much for your attention.